Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 142 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, XDS, a 45-year-old male patient was admitted to your burn ICU a week ago following a 40% total body surface area, abbreviated as TBSA, burn to his left side with likely inhalational injury requiring ventilator support. Last night he had a maximum body temperature of 38.9 degrees Celsius, a WBC of 18 × 10⁻³ cells per millimeter cubed, an increase in macroscopically purulent sputum production. He was hemodynamically stable, with no new onset of organ dysfunction. His chest X-ray was difficult to assess due to his inhalational injury. A catheter-directed bronchoalveolar lavage, BAL, is done for suspected VAP and the culture is sent to the microbiology lab. So my question to you is, which of the suggested courses of action listed below would be the most appropriate in XDS's clinical scenario? Would it be A. Send blood and urine cultures, and await their results before initiating empiric antibiotic therapy, or B. Await preliminary quantitative culture results before initiating empiric antibiotic therapy, or C. Use gram stain results to determine empiric antibiotic regimen, or would it be D. Initiate broad-spectrum empiric antibiotic therapy for suspected MDR-VAP? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Initiate broad-spectrum empiric antibiotic therapy for suspected MDR-VAP. The patient has suspicion for MDR-VAP, as evidenced by the presence of clinical signs of infection, the patient's increased sputum production, and the patient's having been in the ICU for 5 days or longer. Empiric antibiotic therapy should be initiated after obtaining a respiratory culture and be based on patient-specific risk factors for MDROs, together with local pathogen prevalence and antibiotic susceptibility, to increase likelihood of providing timely appropriate antibiotic therapy. That makes answer D correct. Gram stain results are often non-sensitive for causative pathogens, and waiting for preliminary or final respiratory culture results, as well as blood or urine cultures, may cause an unacceptable delay in appropriate antibiotic therapy. That makes answers A, B and C incorrect. Let's move to the next question, please. And the next question reads, MJJ, a 64-year-old female patient is admitted to your MICU with respiratory failure. She has a past medical history significant for type 2 diabetes mellitus, COPD and CAD. She requires intubation due to severe COPD. She was hospitalized 2 weeks ago for a total of 10 days due to a COPD exacerbation. During this previous admission she was treated with IV azithromycin. On day 4 of the readmission, the chest physician noted a worsening infiltrate in MJJ's left lower lung base, increased sputum production. Compared to baseline, she had a maximum body temperature of 38.8 degrees Celsius, worsening oxygenation, despite previous improvement in initial COPD exacerbation. The chest physician suspects clinical VAP, and sends a semi-quantitative tracheal aspirate to identify causative pathogens. The local MICU prevalence of MRSA is 30%, and the most active beta-lactam antibiotic against Pseudomonas aeruginosa on the antibiogram has 80% activity. Which empiric antibiotic regimen listed below would be the most appropriate for MJJ's treatment now? Would it be A. linezolid plus tobramycin, or B. ceftriaxone plus azithromycin, or C. cefepime plus tobramycin plus vancomycin, or would it be D. azithromycin plus moxifloxacin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. cefepime plus tobramycin plus vancomycin. Although this patient is suspected of having early onset VAP for the current admission, a history of recent intravenous antibiotic therapy is a risk factor for MDROs. Empiric antibiotic therapy for VAP in patients with MDRO risk factors should include agents active against Pseudomonas aeruginosa and MRSA. Empiric combination therapy against Pseudomonas aeruginosa is recommended to increase the likelihood of appropriate antibiotic therapy that makes answer C correct, and answers B and D incorrect. With a beta-lactam antibiotic as one of the preferred agents, answer A is incorrect. Atypical bacteria coverage is not necessary because their prevalence is low, although consideration should be given if there is a poor response to initial therapy. Let's move to the next question, please. And the next question reads, OJS, a 35-year-old male patient who sustained several chest and orthopedic injuries during a motorcycle accident is rushed to your accident and emergency department. He has been mechanically ventilated for the past 8 days. During the same period he was diagnosed with VAP due to Klebsiella pneumoniae. The intensivist in the ICU team treated OJS with appropriate empiric IV antibiotics. His oxygenation has improved. His WBC temperature curve has also decreased. So my question to you is, for how long should the intensivist treat OJS's VAP with definitive antibiotics? Should it be for A. 14 days, or B. 10 days, or C. 7 days, or should it be for D. 24 hours after resolution of clinical signs and symptoms? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. 7 days. Based on the NBME trial and related meta-analyses, the most recent IDSA VAP guidelines recommend definitive antibiotic therapy of 7 full treatment days for all patients. This is further emphasized in this patient, who has VAP caused by Klebsiella spp, which are lactose-fermenting gram-negative bacilli, and who received appropriate empiric antibiotic therapy and had an appropriate clinical response during therapy. That makes answer C correct. Answers A, B and D are incorrect. And the next question reads, TAJ, a 48-year-old female patient was admitted to your MICU with a chief complaint of respiratory failure secondary to severe 2009 H1N1 influenza infection. She requires ventilator support. She is diagnosed with septic shock associated with influenza and a secondary MSSA pneumonia. The intensivist fixed an internal jugular vein CVC prior to MICU admission while the A&E team was resuscitating TAJ. She still requires the CVC line. Her hypotension and fever resolved 3 days after MICU admission. She now has a new body temperature of 38.7 degrees Celsius. Her leukocytosis is also worsening on day 5 of her MICU admission. Her chest X-ray shows no changes. Which of the following would be the next best course of action in TAJ's case? Would it be A. Send 2 sets of blood cultures, one from the catheter and one from a peripheral blood sample, or B. Remove CVC, or C. Perform bronchoscopic BAL for suspected VAP, or would it be D. Initiate broad-spectrum antibiotic therapy for a new sepsis episode? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Send 2 sets of blood cultures, one from the catheter and one from a peripheral blood sample. In the absence of other suspected sources, i.e., no change in chest X-ray, CLABSI should be suspected as the cause of new-onset fever and leukocytosis, given the emergency placement and related duration of the CVC. That makes answer C incorrect. Although catheter removal should strongly be considered, cultures should be obtained before catheter removal for documentation if the patient has a bloodstream infection. That makes answer B incorrect. Initiation of antibiotic therapy should be considered, if appropriate, but only after cultures of the suspected source are obtained. That makes answer A correct, and answer D incorrect. Let's move to the next question, please. And the next question reads, MTB, a 31-year-old male patient is admitted to your MICU from a smaller neighboring hospital. He has a chief complaint of severe, alcohol-induced, sterile acute pancreatitis. 5 days after admission at the neighboring hospital, he had multiple organ failure, including respiratory failure requiring tracheostomy. A right internal jugular CVC was placed on the patient's admission to the neighboring hospital. On MICU day 3, MTB has a maximum temperature of 38.9 degrees Celsius. His primary nurse obtains 2 sets of blood cultures and removes the right internal jugular catheter. She sends its tip for culture. So my question to you is, which of the regimens listed below would be the most appropriate for empiric management of MTB's suspected CLABSI? Would it be A. vancomycin plus cefepime plus tobramycin, or B. cefepime plus linezolid, or C. fluconazole, or would it be D. daptomycin plus ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. vancomycin plus cefepime plus tobramycin. This patient, who is suspected to have CLABSI, has risk factors for MDROs, given that he was hospitalized for 5 or more days. Empiric antibiotic therapy choices should include agents active against MRSA and MRSA as well as Pseudomonas aeruginosa. That makes answer A correct, and answer D incorrect. Linezolid is active against MRSA, however it should be considered only for definitive therapy because its empiric use in patients with CLABSI is associated with worse outcomes. That makes answer B incorrect. Fluconazole may be considered in addition to antibiotic therapy, but monotherapy isn't recommended empirically. That makes answer C is incorrect. Let's move to the next question please. And the next question reads, MTB is diagnosed with Klebsiella pneumoniae CLABSI. The intensivist initiates the appropriate empiric antibiotic therapy which is followed by a good clinical response. His bacteremia doesn't persist, so my question to you is, which of the following would be the most appropriate duration of CLABSI therapy in MTB's case? Would it be A. 28 days, or B. 3 weeks, or C. 2 weeks, or would it be D. 5 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. 2 weeks. The guideline recommendation for definitive antibiotic therapy duration is 7 to 14 days from the first negative blood culture in patients with uncomplicated CLABSI. Longer durations of therapy should be considered in patients with persistent bacteremia or if the patient has a poor clinical response. That makes answer C correct, and answers D and B incorrect. Patients with complicated bacteremia, e.g., endocarditis, septic thrombus, chronic intravascular hardware, should receive 4 to 6 weeks of therapy. That makes answer A incorrect. And the next question reads, KMK, a 35-year-old female patient has had flu-like symptoms for the past 3 days. Today she presents to your accident and emergency department from her home, with a chief complaint of severe fatigue, shortness of breath and rigors. PET vitals include a heart rate of 120 beats per minute, a MASP of 70 mm of mercury, a respiratory rate of 24 breaths per minute, a maximum body temperature of 39.3 degrees Celsius, an arterial oxygen saturation (SO2) of 85% on room air. This is the middle of the flu season, with a high prevalence of influenza A and B. A nasal swab is done and sent for rapid diagnostic testing for suspected influenza infection. Shortly thereafter, KMK is intubated for severe respiratory failure and admitted to the MICU. In addition to antibiotic therapy for CAP, which of the interventions listed below would best be considered next? Would it be A. Give oseltamivir, or B. Give amantadine, or C. Await rapid diagnostic test results before initiating influenza-specific therapy, or would it be D. None? The patient is outside the time window to effectively treat influenza. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Give oseltamivir. This patient likely has severe influenza amid a local seasonal outbreak. Local infection patterns suggest a prevalence of influenza A and B strains. Empiric influenza-specific therapy against these strains should be initiated in patients with severe influenza before confirmatory lab results are known to avoid a delay in appropriate therapy. This makes answer C incorrect. Neuraminidase inhibitor-based therapy is recommended for modern influenza A and B strains. That makes answer A correct, and answer B incorrect. Even if they are outside 48 hours from symptom onset, patients with severe influenza have benefited from therapy initiated beyond this period. That makes answer D incorrect. Let's move to the next question, please. And the next question reads, SDP, a 27-year-old female patient was admitted to your MICU with severe acute hypoxemic respiratory failure which required ventilator support. She is hypotensive and requires norepinephrine after fluid resuscitation. She has AKI and is awaiting a renal consult for CRRT. A rapid diagnostic test of nasal washing suggests influenza B, which is consistent with this year's local influenza epidemiology. An NGT was fixed on her admission to the MICU. So my question to you is, which of the regimens listed below would be the most appropriate for the treatment of SDP's severe influenza? Would it be A, IV peramivir, or B, inhaled zanamivir, or C, enteral oseltamivir, or would it be D, enteral amantadine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, enteral oseltamivir. Neuraminidase inhibitors are the mainstay of treatment because resistance to adamantanes has developed in contemporary influenza A strains, and these agents have no antiviral activity against influenza B. That makes answer D incorrect. Inhaled zanamivir is not appropriate for administration to mechanically ventilated patients. That makes answer B incorrect. Intravenous peramivir also is available, however, data are limited for its use in critically ill patients with severe, complicated influenza infection. That makes answer A incorrect. Enteral oseltamivir is the preferred therapy for current influenza B strains in critically ill patients with severe, complicated influenza infection. That makes answer C correct. Clinicians should be mindful of the need for renal dosage adjustment, if necessary. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 143.